Good morning again. It is a great honor to present on behalf of Professor Nabil Shakfeh. The European guidelines on vascular graft infection will be available soon, and Professor Melissano and Professor Vermassen were in charge for the thoracic and thoracoabdominal aortic graft infection in these guidelines. And the first thing that they noticed was that the literature reports about thoracic and thoracoabdominal infection were scarce with anecdotal reports. So the first thing that they performed was a systematic literature review. With these strings about thoracic aortic and infection, a research was performed on the most important health search engines, and 1,657 publications were identified. Among them, 4 multi-center series, 13 single-center series, and many case reports were identified for a total of 233 patients. These are some insights from the meta-analysis. They observed that the clinical presentation of this kind of patient with infection of stent graft or graft is frequently associated in most of the cases with fistula. That could be aortoesophageal, aortobronchial, or both. And the clinical presentation sometimes is dramatic, as you can see in this picture from our experience. For what concerns the management, several options are possible nowadays for treatment with patients with infection, such as conservative treatment, fistula repair only, open repair with or without fistula management, and endo repair with or without fistula management. And the overall reported mortality goes from 16% to 72%. This is another case of our experience, and for what concerns the mortality, the meta-analysis found out that for conservative treatment at 5 years of follow-up, the mortality is 100%, as far as open repair without fistula repair. So going inside the guidelines, possible treatment are nowadays possible for treatment of patients with thoracic and thoracoabdominal infection. The first one is conservative treatment with antibiotics associated with or not with percutaneous drainage and irrigation. This kind of approach may be considered for patients with high surgical risk and for a patient with suspected infection without fistulization. Another option is represented by in-situ reconstruction with total or partial removal of the graft associated with debridement and in-situ reconstruction. And a complete removal is recommended in fit patient, instead in patient with partial infection and a partial explantation may be considered. The third option is represented by extra-anatomic reconstruction. In this case, a ligation of the aorta is performed with stump reinforcement associated with debridement and extra-anatomic reconstruction. The guidelines underline that aortoesophageal fistula is associated with very high mortality. This evidence is more frequent after endograft repair compared with the surgical graft. The conservative treatment in case of aortoesophageal fistula is almost uniformly fatal and is not recommended except in palliative setting. Esophageal stent alone also is insufficient and is not recommended. TEVAR is indicated in patients with aortoesophageal fistula in acute setting to stop bleeding, and it improves overall mortality, but is a bridge therapy to definitive treatment. And this kind of definitive treatment is normally a 2 or 3 stage procedure with closure of the fistula or esophageal resection, removal of the endograft or of the surgical graft, and vascular reconstruction and repair of gastrointestinal continuity. Treatment of patients with aortic infection is complex, so the guideline proposes an algorithm. And as you can see in this algorithm, patient with infection, if arrived with acute bleeding, could be treated on the left side of the algorithm with the stent graft. Then, if this patient are unfit for surgery, could be treated conservatively with antibiotics, drainage, and irrigation. Stable patients unfit for surgery also are treated with conservative approach. Instead, stable patient fit for surgery and patient previously treated with TEVAR and now stable and fit for surgery could be treated surgically, and it depends on the disease. In case of no fistula, the graft explantation is performed total when it's possible or partial when it is well incorporated, associated with vascular reconstruction and prolonged antibiotics therapy. In case of esophageal repair, the closure of the esophagus is performed with suture or esophagectomy associated with graft explantation and vascular reconstruction. Instead, on the right side, in case of airway fistula, the closure of the airway defect is performed with bronchial suture or pulmonary resection. In this case, it's possible to remove the graft or to maintain the graft into the aorta associated with prolonged antibiotic therapy. So in conclusion, thoracic graft and endograft infection are associated with very high mortality rates. The outcome of conservative treatment is ominous, and intervention may be justified in most of patients. When emergency TEVAR is performed, is followed by concomitant or late fistula repair, outcomes are improved. Thank you for your attention.